I would like to thank the organizers for giving me this opportunity. Today I'll be talking about how to manage the endocrine side effects of immune checkpoint inhibitors. I don't have any conflict of interest in this. The prologue, we already know the talks have been there. The immune checkpoint inhibitors are immunomodulatory antibodies that are used to enhance the immune system. Indications, and so its usage is increasing rapidly. So as endocrinologists, we need to be aware of this problem, and also we need to address and manage and diagnose this problem in our patients. So these agents tend to trigger anti-tumor immunity by removing key regulators that inhibits T cell function, and as expected, they tend to cause autoimmune-like reactions and side effects, which are called immune-related adverse events. And this can impact any organ system. And one good thing about it is, from the physician perspective who's looking to diagnose the problem, is that it usually behaves almost similar to the autoimmune disease that affects that organ. So we don't have to learn a new chapter of textbook looking into the pathophysiology and everything. The only thing is that whichever organ it's affecting, it manifests in the same way as an autoimmunity that affects that organ. For example, a colitis that happens with this disease would behave like a Crohn's disease. So what I'm going to do is to tell you how to manage endocrine side effects. The flow of presentation would be the endocrine side effects of this group of drugs and how to manage it. Let me give you some general statements about this group of diseases which I am going to manage today. The majority of immune checkpoint inhibitor treated patients experience at least one of the immune-related adverse event. That's the data that's saying, and the rate and severity of which vary with the different agents. As you can see in this diagram, you can see that the incidence is up to almost 20% with hypothyroidism and hypophysitis, and also adrenal insufficiency. Also, one thing you can see is that these blue lines and these maroon lines, these are combination drugs. So when these immune checkpoint inhibitors are used in combination, the adverse events towards the endocrine system also gets aggravated. The severity of these adverse events have been graded by National Cancer Institute by a common terminology, where grade 1 is mild, grade 2 is moderate, grade 3 is severe and medically significant, grade 4 is life-threatening, and grade 5 you are no longer needed there to treat. So there is a set pattern of general principles of how to manage these side effects of immune checkpoint inhibitors. But in case of endocrine organs or endocrine adverse events, there is a bit of a change in the line of management. The usual treatment line that is mentioned is supportive management, high-dose steroids, and the cessation of the therapy for some time if the side effect is significant enough. But in case of endocrine side effects, the high-dose steroids have little or no role, except for the case of hypophysitis, where you can use it for some time. Mostly, you don't need to stop the therapy in endocrine side effects, and hormone therapy is the cornerstone of treatment, as we know with most of the endocrine diseases. And most of the other side effects are reversible when you stop the drug. But in case of endocrine side effects, usually the gland gets damaged most often than not. That usually the damage persists. So even if you stop the drug, the damage persists, and you have to continue with the hormone replacement therapy of that particular gland which is involved. So that's the reason probably that there is no recommendation as to stop the drug. You can just continue it. You just pray that it doesn't happen to you. But as the incidence is so high, as I mentioned, the incidence with certain drugs can be up to 20%, and it's mentioned that at least one adverse event is expected when you treat the patient for a significant duration of time. So it's always good to be prepared for the side effects that's going to happen. It's something like you are expecting the side effects. Only thing is that we need to recognize early, evaluate early, diagnose early, and treat it as soon as possible in the best possible way. So the guideline says that you need to do a free T4 TSH at baseline and every 4 to 6 weeks. And adrenal, you need to initial evaluation by 8 AM cortisol. And in borderline cases and suspicious cases, you need to follow up the same investigation along with plus or minus ACTH. And pancreas, obviously, we need to do a A1C and FPG at baseline. And in high-risk cases, where there are associated additional risk factors, you need to repeat it every time when you're giving a new cycle. The most difficult case scenarios that's going to come up here is the central hypothyroidism, or the pituitary involvement by hypophysitis, which as endocrinologists, even we find it difficult at times to diagnose in patients, especially in the early early scenarios. So those cases to get diagnosed in the early becomes a difficult thing. Coming to thyroid dysfunction, hypothyroidism is commonest, and it usually manifests as thyroiditis. As you can see, most of the cases, the most common thing is the thyroiditis and also the permanent hypothyroidism, finally ending in hypothyroidism. So always we need to think of that hypophysitis component also. So as I mentioned, you need to screen in the beginning and then every 4 to 6 weeks, and based on the abnormality that you recognize, like if the free T4 is normal and the TSH is slightly increased, just like the other guidelines, if the TSH is more than 10, you treat it. If it's less than 10, you can even observe the patient, follow up the patient, and if it's moving up, you treat it. And if the free T4 is less, that is overt hypothyroidism, you start treatment immediately. But always look for that scenario of low free T4 with normal or low TSH, which may indicate hypophysitis, where you need to be careful and diagnose early and treat early, because that's one scenario where you may miss the condition. Thyrotoxic symptoms, usually, most likely it is going to be the thyroiditis, that is the picture that is there, but rarely it is mentioned that there could also be stimulation of Graves' disease like scenario. So if that thyrotoxic picture is persisting for a period of more than 6 weeks or is severe enough, you may evaluate the patient for a cause other than thyroiditis, usually Graves' disease. So in a grade 1 asymptomatic patient or less than 10, you can just observe. Grade 2 with TSH more than 10, you just treat the patient. But in severe cases, the patient might require admission. We should keep a lower threshold of treatment in young, symptomatic, and antibody-positive patients, and also we should give a lower starting dose for patients with comorbidities. One difference in treatment of this group of diseases management is that we should always watch out for recovery, because this is most of the time the endocrine side effects are irreversible, as I've already mentioned, has been shown earlier by the speaker also in a slide. But still, we should be aware that it could recover, and in case that happens, we should be the first one to recognize, rather than the patient by themselves stopping the treatment and coming to you saying that, see doctor, I am not on medicine and still I am normal. So that shouldn't happen. So in the same way with hypothyroid assessment also, in the early phase you can give beta blockers, and with moderate symptoms and severe symptoms you may have to treat or even stop the drug if the symptom is almost mimicking something like a thyroid storm. So now coming to the adrenal aspect, here one difference that they repeatedly point out in the guideline is that all suspected cases should be referred to for an endocrine consultation. We usually say that a cortisol value less than 3 can indicate adrenal insufficiency, or it could be exogenous steroid suppression, because all these oncology patients may be on some steroids sometimes. And a value more than 15 may be again normal, or it could be due to the hydrocortisone that the patient is receiving. And doing ACTH in adrenal insufficiency, the value may be high in primary, normal or low in secondary or central. And central adrenal insufficiency, as I already mentioned, is very difficult to diagnose, and the only way to diagnose at times is to look for evidence of other hormonal dysfunction or imaging. Aldosterone axis also need to be evaluated in primary adrenal insufficiency, and with adrenal and pituitary diseases, we should always keep a low threshold for imaging studies and for diagnosis. So as I mentioned, you always do a baseline cortisol in all these patients, and if the cortisol is less than 3, you straight away start initiation with the treatment. If it's more than 15, you are pretty confident, especially if the patient is not on hydrocortisone, you are pretty confident that probably the patient doesn't have it. But in borderline cases, it becomes very difficult to diagnose, and then you may have to go for corroborative evidence, additional findings that may be there, and the clinical scenarios and the common sense. Treatment, you should start empirically itself if there is a high suspicion or with the borderline values. We should remember that synactin stimulation test is not beneficial in pituitary onset of adrenal insufficiency, because the adrenal is still functioning, that the synactin will stimulate the adrenal and the cortisol value may come normal. So again, here, the difference is that even in mild or suspicious cases, it's better to hold the immunotherapy until the patient is stabilized with adequate dose of steroids, and in moderate and severe cases, you may even require admissions. So hydrocortisone allows for the recreation of the diurnal rhythm of cortisol, and we need to give it in 2/3, 1/3 dosage schedule, and we should give proper education that the patient doesn't forget the drug, and also in case of emergency, the adequate treatment is given by even the primary care doctor who may be seeing the patient at that kind of emergency. With the case of pituitary, it's usually a hypophysitis, and all cases should require an endocrine referral. Hypophysitis is a rare disease in general population, but it's said that up to 10% of patients who are treated with combined immune checkpoint inhibitors may have this condition. So it's a very high incidence of this condition in patients who are on combination therapy with immune checkpoint inhibitors. So you need to keep a very low threshold for evaluation, diagnosis, and management. And sometimes the onset is quite rapid with this thing that you may have to look at corroborative evidence and start treatment. One thing about pituitary dysfunction is that single hormone may not always be suggestive. Sometimes you may get the evidence from associated low free T4 value, a cortisol level may be borderline, sometimes the testosterone may be low with a normal FSH-LH, and in postmenopausal ladies, if the FSH-LH is inappropriately low, that may be suggestive of the diagnosis. Imaging can confirm because you may get a typical picture of hypophysitis. Treatment again is a short course. This is the one condition of endocrine side effect where you can give a short course of pulse steroids to contain the pituitary inflammation, and replacement with oral steroids can be continued. Pancreas. The onset, the diabetes as a side effect of this group of drug is quite rare. It's less than 1%, but when it happens quite fast, and you need to treat it almost like a type 1 diabetes. You may have to do additional evaluation in the form of A1C, anion gap, and if the ketones are positive, you may have to treat it just like a diabetic ketoacidosis in any other patients. You may look at anti-GAD antibodies to see whether the patient is having autoimmune mediated. So this slide is typically the same slide as would be seeing in a diabetic population, how you evaluate and manage. There is a low threshold for insulin initiation, and insulin therapy has to be used. At least initially, the patient should be on basal bolus therapy, and then education is very critical. And here again, in the early phases, in the mild cases, you can continue with the immune checkpoint inhibitors, but in severe cases, you may have to stop and manage the patient just like a diabetic ketoacidosis. Parathyroid gland also can get involved, where the patient may present with symptomatic or asymptomatic hypocalcemia, where you need to look at the phosphorus and PTH value. The phosphorus towards a higher level, PTH inappropriately low, may suggest a possibility of hypoparathyroidism. The antibodies have been suggested in the guideline, but I don't think it's being done routinely. And treatment, obviously with oral calcium and active calcium is to be given here, and vitamin D deficiency need to be corrected, and severe cases need to be managed by IV calcium gluconate. When this much of a problem can happen with a group of drugs, can we predict the risk? There are actually research going on, and there are certain possible predictive biomarkers which have been suggested. You can see that there are a lot of possible predictive biomarkers that is given. And when there are too many answers to a question, that means that there is no definite answer. So that's what's happening. There is no predictive one. Otherwise, they wouldn't have that. They would have just given one value. So summarizing, use and indications of immune checkpoint inhibitor therapy is increasing. So also the endocrinopathies associated with it. Onset is often rapid. Baseline screening and regular monitoring with low threshold for evaluation is required. Once diagnosis is reached, treatment is in the usual lines. The only exception is being on the lookout for a possible recovery of the condition. Often, in the actual clinical practice, often the reports come borderline. And when in doubt, the only thing that saves you is common sense. Thank you very much.